When it comes to your health, one answer is never enough. Every diagnosis comes with questions. Every headline comes with uncertainty. And in a world overflowing with information, it's hard to know just what to trust. That's where we come in. Each week, Second Opinion brings together leading medical voices across every field of medicine, from mental health and sexual wellness to infectious disease, chronic illness, and the issues shaping our lives right now. We go beyond the sound bites, we challenge assumptions, and we give you the clarity you deserve, because your health is not a headline, it's your life. So stay with us as we break it down, get to the truth, and give you the insight that empowers smarter, healthier decisions. I'm Dr. Ebony Jade Hilton, and this is Second Opinion. Now, up first, Medicaid. So millions of people saw changes in their plans and pricing at the beginning of 2026. With the implementation of the 2025 reconciliation law, many states are cutting funding to Medicaid programs. States will soon begin implementing Medicaid policy changes that may increase the number of people without insurance by 7.5 million in 2034. Joining me now is Adamika Meadows Arthur, CEO of Health Tech for Medicaid. Welcome.
Well, hello. How are you?
I'm doing well, doing better than our policies right now, right?
Oh, yes. Well, I understand that deeply.
Right. You know, Medicaid cuts are often discussed as a budget line item, but what do these cuts actually mean for Black families, especially, Black women who are both caregivers and healthcare workers all in the same?
Well, first, most people don't know what Medicaid is. So Medicaid is the largest insured population we have in this country. So it's an insurance plan. Let's just start there. So most people have heard of Medicare. Medicare, it's a federal program you get over the age of 65. Medicaid, you can have both, Medicaid and Medicare. Those are called dual eligible individuals. But Medicaid is never really called Medicaid. It's only called Medicaid in about 7 states. But it's in all 50 states and our territories. So it's done about 56 different ways in the country. And so, it could be called in Washington State, it's called Apple Care. In California, it's called Medi-Cal. So most people actually don't know that they are on Medicaid in some ways because it's a state and federal partnership. But they truly are on Medicaid. And that's part of the challenge there is that it's called something different in every state because it's a state and federal program. But when I think about, Black folks, Black women in particular, or others, many of us who are caregivers or who are healthcare workers, we're carrying the burden, kind of twice, and we're being paid less every time. These cuts for Black families mean a lot, right? Because if we're losing our health care, or we think we have health care and we're going to the doctor and we get there and we don't have coverage, this means a lot for, medical debt, which is, the number one way that people, lose their assets in this country. It also, leads to a lot around the unpaid care, people delaying going to medical treatment, why people are leaving the workforce the way that they are. So, there's a lot kind of there around just this budget line item around Medicaid cuts. It means a lot for Black families. Over 50% of the births in this country are Medicaid births. Many of those are Black families. There's over 40 million Black people on Medicaid, and much of them, 50% of those are children. So most of our kids and our elderly, get their care covered by Medicaid. So if it's not just us, it's our, it's our cousins, our parents, our neighbors, our friends. It means quite a bit to our communities.
And so what does it mean when they're talking about defunding then, something that has that much weight? What happens when we destabilize both in the workforce and in the insurance coverage that Medicaid provides?
Yeah, I mean, it's a double whammy, right? We are overrepresented in Medicaid as Black people. In some ways, that's a good thing when you think about how Medicaid was actually started. It's a beautiful story. You know, Medicaid was started, it's 60 years old. It started in 1965. Medicaid really is the reason for Black doctors to be able to practice in this country. So before Medicaid, most Black doctors had to kind of go in through the colored entrance of hospitals. They were assistants to white doctors. Many Black doctors were kind of bartering tomatoes and potatoes and cabbages for care because a lot of people couldn't afford care. What Medicaid did was it offered an ability for there to be funding, right? A source of payment for doctors. And so it was a real lifeline for Black doctors and has continued to be. What this means now is that because we're overrepresented in Medicaid, it's great. It means that we have insurance. But what it means now is we are overrepresented in Medicaid. We're also overrepresented in a low wage health workforce. And so when you destabilize both at the same time, it's not just a healthcare issue, it's an economic justice issue. Medicaid is not just a health insurance plan, it's infrastructure. It holds up our entire community.
Yeah. And we keep hearing about work requirements and efficiency. What are those code words for? And what's missing from the conversation when we look at Black workers in home care and nursing and community health roles?
Yeah. So let's just step back a little bit and hear what these buzzwords actually mean. So, in July 4th, something passed called HR 1, which some people know as the One Big Beautiful Bill. I continue to call it HR 1. What that did was took $1 trillion cut to Medicaid as a program. Because Medicaid, you have to think of Medicaid as a state and federal partnership, right? That's why it has different names in different states, different services in different states. So each state has a different set of, there's kind of what I would call the federal floor and the state ceiling. So depending on where you live, you may have more services in Medicaid, but you'll never have less than what the federal floor is. So like everyone has a base Medicaid, right? And then some states have much better, service delivery than others. When we hear about these buzzwords like work requirements, you always have to certify to be on Medicaid, right? You turn in documents and that's how you're given your Medicaid card, or depending on, if you live in New York, you are on Medicaid, right? That is one of the 7 states that actually call it Medicaid. But if you're in Georgia, they call it, Peach program, Peach Health. And, they call it something different in each state. So work requirements, and we've heard this before, and we heard this a lot in the previous Trump administration, is kind of individuals proving that they are working or volunteering or contributing so that they can get their healthcare coverage. This is kind of a weird misnomer. Let's remember that half of the people on Medicaid are children, right? They're under the age of 18. So those folks will not be able to, they're not going to need work requirements. But for the adults, work requirements are going to be a new program. That's not coming into play until 2027, but that is brand new. And we've never really seen that work well. A couple of states have tried it. We've had a lot of pilots and tests. We haven't seen it work that great. And most people already work that are on Medicaid. So, think of, unemployment, right? You tell people I'm looking for a job, and then you get your unemployment check. That we've never had to do to get your healthcare coverage. So that's a little bit of some newer blockades for you to get your care. Another thing is recertification. In the past, we've had to recertify for Medicaid every year. They call that redetermination. They call it these buzzwords. And so typically there are documents you need to turn in. They want to make sure, you're still income qualified. Now there are lots of different categories for how people qualify for Medicaid, right? You could be disabled, you can be genetically unlucky, you can be income qualified, and it changes by state. Some states have programs for individuals who have cancer. Some states have programs for individuals who are new entrepreneurs. Like every state has something a little bit different. But what will happen is now folks are having to recertify every 6 months. We've never done that in this country before, and we're not sure how that's exactly going to work either. So a lot of this is like experimentation, but it's experimenting with 80 million people's care, that's a bit scary.
Right. It's experimenting with their lives, right? And you may bring up so many different points. You can have, fatigue from having to re-register over and over again every 6 months. But also when you think about work requirements, we know that with Black people, there's a saying that we're the last one's hired, the first one's fired. So what do you do when we are losing jobs across the nation and they're tying that to your healthcare? So with everything happening right now, from elections, inflation, global crisis, this thing can sneak under the radar. But why should Black communities and other marginalized communities, for that matter, see Medicaid as a frontline civil rights issue in 2025?
Well, Medicaid's always been a frontline civil rights issue. I mean, I think healthcare has always been a right and a privilege. And in order for us to be economically a part of society, we have to be healthy, right? So that's one of the things I've always said is a part of justice. In order for us to be productive citizens, we have to be healthy so that we can contribute to society. I think you're absolutely correct when you talk about how stressful it is to be thinking about all of the hurdles that are going to happen for you to keep healthcare, not only for yourself, but for your children, for your ill parents, etc. It's a very stressful thing. So we're encouraging new determinants of health for the first time ever. We have this kind of new category, which is like political determinants of health, things we've never seen kind of before. The other thing I will say is that the quality and duration of life will be impacted, not just, and I think people will be delaying care. Some people won't even apply for Medicaid. They don't even want to be bothered with being told no, which we've already, experienced. That's a real travesty where people, are feeling like, I don't even want to partake in the system. As you know, we have a lot of individuals who are feeling that the government is tracking them, or there's, fear of immigration, or all of these other issues that are, wildly a part of the fear mongering that's happening. So when we talk about Black folks and Medicaid, most of us work. We've known this, but we may not have like these traditional 9-to-5 jobs, right? We are home health aides. A lot of us do a lot of unpaid caregiving. Mm-hmm. Is that going to count? Right? We're childcare workers. We're gig workers. We've been helping, Mrs. Jones down the hall. We drive the church van and get seniors, out of their homes. This isn't about laziness, right? It's about wages and support. So I think you have to kind of dismantle this myth that people on Medicaid don't work. Many of them work, and they actually work many jobs. They just cannot sustain a living wage, even with multiple jobs.
Right. And with this being the frontline civil rights issue of 2026, if there is a cut, right, if Medicaid is cut even further or weakened even more than what we're seeing now, what does that mean in terms of Black health outcomes, Black wealth, right? Black workforce stability over the next decade? What happens if Medicaid is allowed to fail?
Well, unfortunately, Medicaid is failing a little bit. It's getting gutted. I mean, $1 trillion being taken from a system is a lot. And, who is going to fill the gap? It's not going to be philanthropy. There's not going to be, a fairy with money that's coming to fill that gap. And it's not going to be quick. It's not like we get this administration out and, 3 more years and we can go back. I mean, think of how many lives will be lost in 3 years. It means a lot for our health, for the Black Wealth Index. It means a lot for jobs and workforce stability. You talked earlier about, if you look at the unemployment rate in the Black community, it has skyrocketed to like lengths that we have not really seen before. So it means more debt. It means more burnout. It means more people dying younger. It means more stress. It means fewer people left to get care. So Medicaid is not a handout. I think that there's a real misnomer. It is an insurance program. Just like everybody else gets insurance through their job, it's an insurance program. But Medicaid is also just a foundation. If you pull that out from underneath a society, the whole structure fails. And unfortunately, I think we're going to, this is a really unfortunate experiment that is happening with elections and inflation and kind of global chaos all happening at the same time. This is really about, people often ask, what is a solution? What do we do? And I think there's lots of things we can do. We can bound in our communities together. Our churches can start putting gyms in churches, and we can start to figure out, how do we keep ourselves healthier? How do we grow some food? And we can start to come back to some of our community roots and start to take care of ourselves. And I think that's what we're going to have to learn how to do as we start to work ourselves through this. I think our Black-led and Black-run CBOs are going to really have to figure out novel and creative solutions to help with this, unique and creative ways that we can help with the work restrictions. And I think we're going to have to advocate. We're going to have to really fight for our lives. And I think that that's a level of fight that we haven't seen probably since 1965.
Right. And it's one of those things, every generation we have a different fight to give, right? But I want to bring in Dr. Roger A. Mitchell. He's the president of National Medical Association, to talk about how this is impacting the workforce. So welcome, Dr. Mitchell.
It's good to be here. Good to see you, Doc.
Yeah. We just talked about Medicaid and how it serves nearly 1 in 4 Americans. This is a huge program. But what is this impact on the Black physicians and the sustainability of practicing medicine, particularly in those underserved communities out in the rural areas, as I'm clearly from? How would what impact will we see kind of immediately based on these changes?
Well, you said it. Black physicians tend to take care of Black patients. We tend to take care of Black patients in a way that others may not take care of those patients, whether it's in rural communities or urban communities. And as has been said, disproportionately, we're on Medicaid. So Medicaid, we know that there are, like you said, 1 in 4 individuals there on Medicaid. And our physicians are impacted because if you remove Medicaid, if you remove this safety net, it destabilizes the whole system. It creates an environment where there's less patients that can pay for their care and more unsubsidized patients. So what does that mean? It doesn't mean that patients that need care won't attempt to get care. Most individuals, if they're sick, they're going to seek care. They may not seek care in the clinic where they used to. They may not have a primary care provider, so they go to the emergency department. And if they do go see to the clinic, particularly federally qualified healthcare systems, then there may be an opportunity for them to get care, but that care is going to be unsubsidized, meaning it's going to be care that has to be given for free. And so anytime the care is given for free, then that margin for organizations and physicians, hospitals that are safety nets, and physicians that take care of these patients, those thin margins create an environment where they might not be able to pay for a staff member. They might not be able to pay for a particular test that they need to provide. So those razor thin margins create an environment where care delivery is compromised because the care is unsubsidized. And so this is a big issue. It's a big concern for the National Medical Association and for our members, because our members take care of communities that are getting their care through Medicaid.
Yeah. And and we over the years we've been seeing this kind of exodus, right, of doctors, Black doctors, having to leave these rural and the low income areas. And what happens in that void? Can you talk to us about the importance of the hospital deserts and what is being left behind with these policy changes, particularly as it pertains to Medicaid?
Well, you said it, right? There are hospitals that are closing in our rural communities. There are doctors that are saying, "Hey, listen, I can't afford to be in practice that's heavily subsidized by Medicaid because I can't give the care that I want to give." And that's extremely important, because these are communities, and not just Black communities, but these are poor rural white communities. These are poor urban Black, white, and Hispanic communities where the commercial insurance is not able to subsidize the Medicaid. So let me say it this way. Medicaid already does not provide 100% of the cost of care. It provides anywhere from 30 cents to 40 cents on the dollar. Commercial insurance gives maybe $1.20 on the dollar. And so oftentimes those of us that treat patients that are largely Medicaid or have a Medicaid population are able to subsidize the care for those that are on Medicaid with those that have commercial insurance. So that mixed type of insurance by our patients is important to us. When you start pulling individuals out of Medicaid and now they're uninsured, they're going to continue to seek care. And that is unsustainable in a business model for physicians that have to keep the lights on, have to employ nurses, have to employ techs, have to pay the premiums on their equipment. These are the types of things that puts physicians out of business in areas where physicians are needed the most, and in an environment where there's a shortage of physicians in this country. We should be doing the opposite. We should be investing in our communities. The HR 1 was never a healthcare bill. It was a tax bill. It was a spending bill. It was a bill that they said they had to cut dollars. And because healthcare is the largest spend in this country, obviously was on the chopping block. But if we really wanted to reform healthcare, we would take the time to actually look at healthcare. We are moving down that road in value-based care, making sure that we prioritize prevention, that we prioritize and give increased incentives for screenings and catching disease processes early in the disease continuum, particularly chronic diseases like diabetes and hypertension, but also cancer screenings and making sure that we're catching and ensuring that there's regular cancer screenings. Value-based care really was the road towards decreasing the cost of care in this country, because we know that healthy individuals cost less than sick individuals. Right. But this bill is not doing that. It's really just cutting the process at the knees.
Right. It sounds like it's doing actually the opposite of that. And we talk about there's 1 in every 4 Americans that's on Medicaid, right? So oftentimes it has to impact you. It has to land on your doorstep for it to have a driving force for you to care about an issue. So how do we talk to those 3 out of 4 who have commercial insurance, or those persons that's not on Medicaid? How would these changes now impact them, their access, their cost of medicine, their health outcomes?
Well, the 1 out of 3 may have a disabled child, right? And that disabled child is getting their support through Medicaid. They may have an elderly individual that is dual eligible. They're not really bringing in any dollars, and they're over 60 years old. So they're getting Medicare and Medicaid, and that Medicare is paying for their prescriptions. Invariably, we have someone in our family that's getting Medicaid. And see, this is the calm before the storm, Doc. This is a calm before the storm, because people aren't really anticipating the impact that it's really going to have. Some people are starting to feel it. because the subsidies are not kicking in yet, and individuals' premiums that are paying on the exchange is going up, and we're seeing it there. But when those individuals start being pulled off the rolls, and individuals that used to be able to get regular care now don't qualify, and when individuals are pulled off the rolls because of the bureaucracy of the things like work requirements or recertification every 6 months, when those individuals get purged and then show up to their doctor's office, they're going to say, what happened? I should be getting this. They're going to be calling their senators and Congress people. They're going to be calling the family members that are the 3 out of the 4, right? They're going to be calling family members and say, listen, I just got kicked off of my Medicaid and I'm fully qualified. There will be individuals that are kicked off of Medicaid that are fully qualified and then are caught in the bureaucracy of recertification. That's actually built in the calculus of the savings that is being suggested by the HR1. And so it's really going to be devastating. And as a forensic pathologist, I often say that I find failed policy on my autopsy table because individuals are going to die because of their lack of access. And then they're not going to want to go when their disease or injury is preventable or treatable at a lower stage. They're going to be accessing things when the disease is further along.
You know, you brought up such great points, how this is impacting patients, how this is impacting the workforce as far as the Black doctors. You know, one of the other things I think about is what are those doctors who are coming up the pipeline, right? Our medical students. With medical school debt climbing, how does Medicaid reimbursement rates and the safety net network factors that play into this pipeline, how does it impact that for them? Are we going to have future Black doctors? Are people going to say, hey, it's not worth the climb when I get there, I can't actually do the work?
Well, Medicaid is one of the issues, right? It is a big issue. Medicaid, particularly in safety net hospitals. I used to be the president of Howard University Hospital, safety net teaching hospital, one of the most historic Black teaching hospitals in this country. And because we were over 80% Medicaid, that those dollars coming in paid the doctors, but also paid an environment where we could teach those residents and teach those students. When you start bringing the Medicaid, the actual subsidized amount of patients away from that hospital, then the amount that the hospital can spend on things outside of care that lead to higher quality care, that stuff starts going down. The clinics that we send our residents and medical students to, often in urban centers, rural centers that are high Medicaid population, we send them there to be trained on patients that often have Medicaid. And so if those patients are either not coming or not paying for their visit, then the likelihood that we're going to be able to train individuals at the higher rate goes down. But also in this HR1 bill is this cap on graduate loans, graduate school loans, which affects the medical community. Because if you cap our loans at $200,000 over the period of time that you could take loans, there are individuals that can't afford to go to medical school without loans. We're talking about loans, things that can be paid back over time, low interest loans, because this country at one point thought it was important for there to be diverse classes and diverse groups from socioeconomic, right? Not just Black people or poor, but socioeconomic conditions, as well as race, gender, creed, religion, and sexual orientation to be in the medical profession. Well, with these caps on these loans, it also limits those individuals that can even get a medical education to those that can afford it. I'll say it like this as well. So this Medicaid is the issue. Yes, it's going to decrease the amount of dollars that is going to be available for our training of our trainees as residents and medical students. This cap on funding for loans for medical school. But also the restriction has been removed by the LCME that required for retention and recruitment diverse classes. So now the medical students medical schools in this country no longer are required to have diverse classes. I went to medical school in Newark, New Jersey. And my Jewish friend that sat next to me, my Italian friend that sat next to me, my Greek friend, my Indian friend, my Asian friend, we all brought a different cultural perspective to how we were learning the medicine. And I have taken that along with what I learned in the science and clinical aspect of my work. I've taken that cultural aspect and feel like a better rounded physician because of that. And I'm sure you had that same experience. So what we're seeing today is really an upheaval of the entire medical practice, and it's going to affect Black and brown people the most.
Yeah, and it's one of those unfortunate things. What we know is that representation matters. We know that outcomes are literally better, whether that's surgical or medical outcomes, when it comes down to race concordance and situational cultural concordance. So, I just want to thank you, Dr. Roger Mitchell and Adamika Meadows Arthur, for this important dialogue. I'm sure people now know that calling their representatives and seeing how we can start to try to right this correction is going to be paramount moving forward in the future. So I thank you both. New studies are showing that colon cancer is on the rise for people under the age of 50. Coming up next, we explain why.
I'm Brittany Noble, Midwest-born, HBCU educated with experience in newsrooms across the country. Well, I've teamed up with Roland Martin to bring to you The Breakdown. This isn't just news. It's our stories, our voice, our community. Join me for The Breakdown, Monday through Friday at midday, only on the Black Star Network.
In 2020, Black Panther actor, In 2020, Black Panther actor, why can I say that? Start over. Okay. In 2020, Black Panther actor Chad Boseman shocked the world when he died of colon cancer. This is a 43-year-old who kept his stage 3 diagnosis private while continuing to film on the big screen. His death shocked us all, but it also heightened awareness around this illness. And now, recent studies reveal that colon cancer deaths are on the rise for people under the age of 50. In fact, by 2023, colorectal cancer became the leading cause of cancer death for Americans under 50, surpassing breast, surpassing lung, and surpassing other cancers. Joining me now is Dr. Nadia Sanford, a gastroenterologist who is extremely passionate about colorectal cancer screening. Welcome, Dr. Sanford.
Hi, thanks so much.
Yeah. So let's start with the basics. What is colon cancer and what are the symptoms that people should look out for?
So colon cancer usually starts out as something innocuous like a polyp. So it's a small growth in the colon years before you would even see it turn into a tumor, which is basically an 8 to 15 year process going from a small, tiny little polyp that could grow into a tumor. It is the third most common cancer and the second leading cause of cancer death. But it is one of two preventable cancers if people do their appropriate screenings, the other being cervical cancer.
And what age group or sector of population is typically impacted by colon cancer?
Well, as you've alluded to, we've kind of shifted our focus on the younger folks. Before 15, 20 years ago, it was something that was seen in 55, 60-year-olds, which was why initially the screening age was age 50. The older you get, the more propensity you have to have these polyps, and then the more propensity that if you don't have your age-appropriate screening, that these polyps can turn into a cancer later on.
Yeah, it's one of these things that it does seem scary to hear how young people are. We had actor Chadwick Boseman, only 43 years old, and earlier this year we saw a 35-year-old beauty queen out of California die from colon cancer. So why are we seeing colon cancer impacting more and more younger people? What's happened?
Yeah, it's keeping us up at night. It is a shift. It seems like folks born after 1990, we are seeing this happen more often. And unfortunately, when we catch it, it's more at an advanced stage. We don't know why. Of course, we don't know why. We're still trying to kind of pick this up after being recognized over the last several years. We actually just changed the screening age from 50 to 45 a few years ago after seeing this trend upwards. There's some thought processes as to why. Diet, ultra-processed foods, red meats, especially if they are well done. The question is if those carbons, the well done, that little char that you're seeing, if that can cause some problems in terms of altering the DNA in the colon. There's something called the microbiome in your intestinal tract that is good bacteria as well as bad bacteria. And some of these bacteria can also be altered that potentially could be playing a role in terms of these earlier cancers. But again, it's scary. It's 1 in 5 people under the age of 50 are going to be these new diagnoses of colon cancer.
Yeah, and we said we changed it from 50 to 45, but Chadwick was 43. The beauty queen was 35. Why are we waiting so late for testing? Should this be pushed even further back?
Well, the problem with that is cost effectiveness. So, of course, our healthcare system has its pluses and minuses, and we have to look at what is cost effective for the system as a whole. They'll do what are studies for cost effectiveness and kind of test each age and the incidence or how often this cancer is happening to come up with an age. And unfortunately, right now, we're not to the point where it is cost effective to screen any earlier than age 45. Now, remember, we're talking about average risk screening, meaning that there's not a family history or genetic issues. That age changes in terms of how quickly we start the screening process in those folks.
You talked about ultra processed foods, and we're now seeing studies that link the number of alcoholic drinks that a person consumes to colon cancer. So what are you seeing in your research in that arena?
So that study just came out this month about if you do more than 2 alcoholic beverages a day, that may increase your colon cancer risk, especially in the folks that are younger. Again, not knowing the specific reason why, maybe there's an effect on the microbiome from the alcohol. Also, there may be an effect from metabolites from the alcohol when your liver breaks the alcohol down that may affect the DNA in the colon and also contribute.
And you mentioned earlier that, this cancer, colorectal cancers in particular, are actually pretty treatable, right? If we catch these earlier. But studies are showing that colorectal cancers have seen a 1% increase in deaths every single year since 2005, while the mortality rate of every other type of cancer has decreased. Why do you think that is?
Well, part of this is, again, we're talking about the younger folks, and so they don't think that this is going to happen to me. And so some of these symptoms that they are experiencing that may be warning signs in somebody 50 and over, they just kind of, say, well, this is not anything, it's hemorrhoids or it's something else. And so unfortunately, by the time we get to them, it's advanced. If we can catch colon cancer at stage 1 or early, it's 90% or greater curative. So the earlier we get to it, the better your chance for cure is. But again, with folks not being cognizant of what to look for, symptoms to look for, your change in your stools, the size of the stools, not just rectal bleeding, abdominal pain, bloating, unintentional weight loss. If they're not looking at that and going to see a doctor to get referred for that, then it gives us a lag time in terms of trying to kind of do the diagnosis and do the appropriate therapy afterwards.
And so if persons have those symptoms, if they have changes in their stool pattern, right? If they have different colors, bright red blood, if they see some darkness to their stool, should they go in to get a colonoscopy? Will insurance actually pay for that? How do they get their doctors to actually write that prescription for them?
So again, we're all cognizant of what's going on with the shift in age. So, like I said, 15, 20 years ago, people, it's a hemorrhoid, we'll treat it like that. And now it's pretty much, we're going to do a colonoscopy. Now, insurance is not going to do that as a screening, meaning that you may have to do that under what's called a deductible. So if you've not met your deductible with your insurance, there may be some cost sharing for you. But I don't have any doctor colleagues that I know in primary care who would not refer for any kind of worrisome symptom, to be sure for peace of mind that that's not what we're dealing with.
And for those who may want peace of mind, what about Cologuard? Is that a substitute for colonoscopies? Is that something that younger people can even get their hands on? What do they do?
So Cologuard is only for average risk screening. So not because you have symptoms, not because you have family history, not because you've had polyps before, that doesn't qualify for that. That is only strictly average risk starting at age 45. That is a DNA test that they do where you submit a whole stool and they'll look for abnormal DNA. And if abnormal DNA is found, then they will refer you for a colonoscopy.
And is that something, do you need a prescription for Cologuard? How do they get their hands on that if they are qualifying persons?
So a primary care physician or some physician would have to send an order for the Cologuard to be sent, and then that gets mailed directly to the patient's house. Then the patient mails it back with the instructions that are sent, and then the physician gets the results and then relays the results to the patient.
There you go. Now, is there anything that if people say, hey, I want to reduce my risk of colorectal cancer, what would you tell them are the top 3 things that they should do to hopefully help them prevent being one of those persons who succumbs to this disease?
High fiber diet. So again, not the ultra processed foods, raw foods, Mediterranean diet, things like that. The fattier things, and again, trying to avoid the well done meats, because again, there's a potential link between those hydrocarbons from the char. Obesity is thought to be a factor in a lot of cancers. And so trying to do exercise, not live that kind of sedentary lifestyle, and then not smoking and not overindulging in things like alcohol, because again, these are potential carcinogens, or what we call things that potentially can lead to cancer and alter the DNA.
You know what? Thank you, Dr. Sanford. You have given us a lot to think about. People, check your stool. It is actually important, and go get those screenings if you see anything that's concerning.
Absolutely. We can put you to sleep. It's a wonderful nap. Don't not do it. Okay.
Right. And that's my job. That's what I do.
That's right.
Thank you so much for joining us, Dr. Sanford, and we'll see you soon.
Thank you.
Now, still to come, we're checking what's in your pantry. Is there chips, cookies, ramen noodles? We've got a doctor that's going to rearrange it all.
Hey y'all, welcome to The Other Side of Change, only on the Black Star Network and hosted by myself, Bria Baker, and my good sis, Jamira Burley. We are just 2 millennial women tackling everything at the intersection of politics, gender, and pop culture.
And we don't just settle for commentary. This is about solution-driven dialogue to get us to the world as it could be and not just as it is.
Watch us on the Black Star Network, so tune in to The Other Side of Change.
The calories that the average American adult consumes are from ultra-processed foods, also called UPFs. And UPFs have become a popular topic of conversation and a growing concern in public health. Joining me now to address this problem is Dr. Ema Spalding, an emergency medicine and weight loss physician. Welcome, Dr. Spalding.
Thanks for having me.
Yeah. So what are some of these UPFs? Like, what are some examples that people may not even think of are ultra-processed foods?
I don't know. I don't know if people wouldn't think of them as that. I just don't think they think about it in general. If you go to any grocery store, I would say 70% of what's in there is probably processed to ultra-processed foods. So all your cereals pretty much, excuse me, a lot of your baked goods, anything with a bunch of extra sugar in it, if you go to the bakery or whatever, you got to look at the deli meats. If you were to go to Publix, for example, or I don't know whatever local grocery store people have, there's Publix in Atlanta, for example, there's Publix in the South. But, your deli meats have a bunch of nitrates in them. I think Boar's Head is probably one of the few that doesn't, if you're actually checking. A lot of packaged foods, talk about things like ramen noodles, a bunch of canned goods. Some canned goods are okay, and some processed foods are still actually somewhat okay for you because they do have some nutritional value, pastas, some, boxed or canned or pre-cooked rices, things like that. So there will be some, but it's probably about 70% of the food out here is ultra processed food. It's unfortunate. So.
And it's one of those things, if we go backwards, how do you define what is ultra-processed food? Like, for the person who's never heard this before.
Well, ultra-processed food is going to be any food that, well, let's talk about what's not ultra processed first, right? So many of the meats you get, you got to be careful with ground beef, maybe ground turkey, ground meats. But most of the meats you get are going to be just a little bit processed. The dairy is going to be a little bit processed, like milk. Fruits, pretty much there's no process, just depending on where they're sitting at. Was it a clean environment? Were there bugs? Is there mold? Things of that nature. But mold's a good sign that something is very organic, because things should go bad pretty quickly. So those are not processed foods, right? So ultra processed foods are anything that's been through, how can I say, well, it's a process. It's been through a process that does things like it could strip the food, it could enrich the food. If you look at our breads, for example, our wheat, our enriched, all this enriched flour we consume. Bread is not supposed to last as long as it does. If you go get a loaf of bread from the store, it should not last you a month. It should be done in 3 to 5 days. So we strip away so many things, nutrients, from things like that to make them last longer. You get enriched rice, sugar gets processed, So, I mean, anything that is an organic, that goes through some process of stripping it down or adding to it, sometimes adding preservatives. For example, we add high fructose corn syrup to things. Why? Because it preserves well, it travels well. It's a very stable type of sugar syrup. So that's why we use it. That's why it's used in so many things. So anything like that is going to be considered ultra processed. And you just have to read the back of it. You have to read your packages. You have to read the back of your, anything that you buy, and to really see. And you don't have to read but three, 4 words before you realize it's probably terrible for you. So
Right. And consuming large amounts of this ultra processed foods, what does it cause? What kind of illnesses do we see at the other end of that?
Well, so if you look at it overall, you've got an obesity issue in America, in the West. I mean, I think, roughly 60% of the population now is obese. And as far as morbid obesity, like truly scary, increased morbidity, mortality, obesity is like 10%. And, hypertension, hyperlipidemia, bad cholesterol. Overall, the main thing, you start to look at cardiovascular disease. You start to look at how much stress are your kidneys under. You have visceral fat being deposited in your belly, in your liver, metabolic syndrome, which is a big problem, a growing problem. So this is the type of things that that these processed foods can cause, eating, especially, the regular large quantities that people eat them in.
And what do you do if, when people come to you and they say, hey, you're telling me that 70% of all the food that I can actually consume in this grocery store has these ultra processed factors in it. What do you do? What can I do?
Well, processed to ultra processed. Yeah.
Right. So what do you tell patients who say, hey, I'm tipping the scale. I know I should not be eating this, but I have nothing else to eat. What can they do to help themselves?
Well, obviously admitting yourself there's a problem is a good step, is the first step. I mean, the next thing you got to do is probably get some help, because if you're not the type of person who's been on it already, it's going to be hard to start on your own, because it's not just about changing your diet. You're going to change your whole lifestyle. You have to become a different person, not altogether, but just certain habits are going to have to go. You have to cut out certain things you consume in large quantities, in some quantities. Some things are going to have to go altogether. So when you say, well, what do you tell them? First thing you have to do is try to start them on the mental and emotional preparation for the journey, because it's, once you start it, stopping it is not really an option. It shouldn't be anyway. So, they say, hey, what am I going to do about this diet? What am I going to do about this? What am I going to do about that? You just got to sit down and help them develop a plan. That's pretty much what we do in our weight loss clinic. Is we don't just give them, say, GLP-1s and meds and stuff. We develop a lifestyle plan, and we help them with we help them track their calories. We help them start activity levels. Okay, week 2 now, week 3 now, week 4, we ramp it up. You know, we pay attention to the labs, make sure their physiology is remaining in homeostasis. I mean, so there's a lot to it, and you got to tell a patient really that this is a journey, but we're taking it together. I'm gonna be right here with you, you know, helping you along the way. At least, you know, if any patient that goes to a doctor, that's what the doctor should be doing with their patients, in my opinion.
And how do people get access to weight loss clinic, right? Is this something that is available at every hospital, or is this specifically for yours?
You know, until I got into it, I didn't realize how they're everywhere. I just got I was just at work earlier, and I was looking at Google in between patients for something, and I saw a news feed, or news story that said Forbes top 10, you know, weight loss options, and it's like these 10 weight loss businesses or clinics that exist somewhere around the country, right? So they're everywhere. I mean, they're everywhere in Florida for certain. I mean, Florida being Florida. So you can, what you got to do is you have to, like you do any business, you got to look up, check the reviews, check the results, because most weight loss clinics actually online track the results of their patients. So you can see what is the average weekly weight loss, what's the average bi-weekly, what's the average monthly weight loss, you know, what are the side effects of these medications, who's having more success, you know, who's highly rated, you know, do you like the staff? I mean, there's all types of factors that people go to clinics or doctors, as you well know. So, I mean, you can easily just Google weight loss clinic in whatever city you're in, and then you start looking at the reviews and compare and contrast. And then what you do is you go visit a couple and you go and see, hey, is this pricing right for me versus this, you know, what is this program? But you don't just want a weight loss drug. That's not enough. That's not enough. The biggest thing for weight loss largely is diet, which is why, you know, when you talk about these processed foods and you combine it with the fact that they're always so readily accessible, because we have a lot of food deserts around the country. I mean, it's difficult. It's really difficult.
Right. You know, you hit on the nail on the head with the food deserts. What do we tell Americans? What do we tell our patients that say, hey, I'm in the middle of a food desert. 70% of the restaurants that's around me are really these fast food chains, and that's basically the only thing I can afford to do. What do we say to them, and what do we say for their children's sake? You know, there's a statistic that 70% of all the food consumed by children are ultra-processed foods, and we're seeing diabetes and hypertension younger and younger ages now. What can we say to give them a glimmer of hope?
Well, to answer the first part of your question, you got to cook. You got to cook food at home. I mean, honestly, if you look at it, let's say you buy a package of, you know, chicken, like thin cutlets of chicken or something like that. And then let's say you buy, you know, some green beans or broccoli, and then you buy some starch. You can buy a bag of rice or some potatoes. That's going to cost you probably, let's see, the average price of chicken back then about $12, and then the green beans about another 20. So, and then the potatoes is about a 70-pound bag of potatoes. So you're looking at about $30-something, right? The average fat, and that's if you take that meal, if you took that food, you could eat on that all day, right? For the whole day, you could eat on that. If you go eat at a fast food spot, okay, if you do that 3 times a day, not only are you going to be paying the exact same amount, if not a little more, you're going to be eating the most unhealthy stuff on the planet, and you're going to be washing it down with some sort of soda or something terrible that's got 50 grams of sugar per serving, which is right. Crazy. So you're going to have to start cooking. So the second part of your question is parents need to be parents. Mm-hmm. That's it. Like that's full stop. That's kids don't control what they eat to a large degree. Your parents do. Well, whatever you put in the house, they'll eat or they won't eat. But you don't have to have all the badness. You don't have to have all that. It's okay to have that stuff every now and again as a treat. That's fine. You know, your body can deal with it from time to time. But you shouldn't be snacking on Pringles every day and candy every day and whatever chips and cookies, whatever cakes. It's a bad idea. Bad idea.
You know, they say if it's not in the pantry, it's not in your mouth. And it's one of the things we have to start to face and say, hey, do I need to buy this right now? And make just different choices. It's difficult. Mm-hmm. I know it is very difficult, but it can mean the difference in a long life and a long, healthy quality life. So
That's true.
we thank you, Dr. Spalding, for your words of wisdom, and we look forward to having you back.
You're welcome. Thank you. Thank you for having me.
Do you snore? Or do you have episodes where you wake up gasping for air? Are you constantly waking up in the middle of the night? Are you tired throughout the day? Well, we've got some help for you. Stay with us.
My brothers and my sisters, this is Bishop William J. Barber II, and I'm coming to you with an urgent call from Repairers of the Breach and all of our partners. From Wednesday, February the 11th to Saturday, February the 14th, it's time to love forward together. We are mobilizing from Wilson to Raleigh. This is a call to all who love voting rights, love justice and truth, who believe in health care for all, living wages, labor rights, and caring for every person in our communities, who believe in life and not shooting people down in the street. We march each morning, February the 11th, 12th, 13th at 9 a.m., beginning at St. James Christian Church in Wilson, North Carolina. And on February the 14th, we gather at Shaw University, march down Fayetteville Street, and we have a rally right there at 10 o'clock a.m. Join us for the Love Forward Together Mass People's Assembly and Moral March mobilization. Visit breachrepairers.org for everything you need to register. This is William J. Barber II, paid for by Repairers of the Breach.
Are you getting a good night's sleep? If you have loud snoring, restless nights, or wake up gasping for air, you may have sleep apnea. Interrupted sleep impacts nearly 30 million people, according to the American Medical Association, yet only 6 million people are actually diagnosed with sleep apnea. Joining me now is Dr. Joy Fremont, owner of Fremont Dental, Orthodontic, and Sleep Treatment. Welcome.
Thank you. Welcome to you. I'm glad you're here with me because I'm here with you. I'm a little sassy, so give me a little second.
And I like the sassiness because you are talking about something that, like we said, it's impacting millions of people. And people need to know what is this diagnosis of sleep apnea? Like, does everyone not snore a little bit? Is that a major problem?
Well, snoring is very common, and as you probably grew up, you knew of someone who snored and you thought it was kind of funny. Even now, a light little snore is cute. So most people do snore just a little bit, but sleep apnea is actually defined as stopping breathing when you sleep, holding your breath. And as a doctor, we actually define it as holding your breath for at least 10 seconds. So those people that do it repeatedly over and over each night, every hour, anytime more than 5 times per hour is considered sleep apnea. So if you hold your breath 10 seconds and keep doing that over and over and over again, then you have sleep apnea.
Now, here's the question I think a lot of our viewers may say. If I'm sleeping, then how do I know? Right? So
right.
How are people being diagnosed with sleep apnea?
There's only one way to actually be diagnosed, and that's with the sleep study. No, you can't wear your smartwatch and they can tell you, you're sleeping fine. Now, sleep apnea is diagnosed primarily by you going to your doctor with symptoms. People are going to have symptoms if they have sleep apnea. The main symptom is excessive daytime sleepiness, that you're tired throughout the day. Even though you might be sleeping, you might not know if you're snoring. You've been with somebody or someone's been with you who has heard you snore. Even a light snore or a loud snore that wakes the whole house up. That's a problem. So it's more than just a snore. Even if you have high blood pressure, I said earlier, you're tired throughout the day, you have morning headaches, that's a huge risk factor. If you happen to have diabetes, if you have hypertension, the list can go on and on. The main thing is if you have any kind of symptoms that don't feel normal, you have to go see your doctor. However, a lot of times they mask it, especially in African-American women. Oh, I'm just tired. It's not a big deal. I'll get over it. And your body ends up overcompensating for this, but you actually do have sleep apnea. No, you're not just tired. Something's happening that's keeping you from sleeping throughout the night. And unfortunately, sleep apnea is very deadly.
And when you mentioned that part, I think that's going to perk some people's ears. When you say that it's actually deadly, that it's not just say, oh, you're snoring and it's making a loud noise. What is the deadly part about it? What does it do?
So what happens if you keep holding your breath and you hold your breath for at least 10 seconds, your heart is not getting the oxygen. The reason I'm so passionate about this is because my father actually died from an episode of sleep apnea. My dad was a physician. I always say, Dad, I know you knew better. You know, growing up, I heard him snore. I thought it was funny. Oh, my dad's snoring. But eventually, as time went on, sleep apnea and lack of oxygen to your heart just puts a beating on your cardiovascular system, and your heart can't sustain that. So when you're sleeping, your whole body is supposed to be calm and it's supposed to be at rest. But when you have sleep apnea, unfortunately, your body wants to live. So it does whatever it can to wake you up. Your heart starts beating really fast. People start to sweat in their sleep. They wake up coughing or gasping for air. People have to use the restroom over and over because your body's doing whatever it can to make you so uncomfortable to wake up so you can breathe. And unfortunately, keep doing that over and over and over again at night, then you're tired throughout the day. So those symptoms end up adding up and adding up and adding up. And eventually you have a heart attack when you're sleeping. You have a stroke in the middle of the night. So people who are 30, 40, and 50-year-old and they're just dying in their sleep, they're not just dying in their sleep. Something is happening that's causing them to die in their sleep.
Wow. For one, condolences to you and your family to hear about your father. That is, how do we prevent that from happening to be in someone else's story? Like, what can people do to treat sleep apnea?
So there are 3 ways to treat sleep apnea. First of all, you have to get a sleep study. I say this to all of my patients. Do not let anyone tell you by looking at you that you do not have sleep apnea. Gone are the days of saying, oh, you have to be an overweight man to have sleep apnea. People can get it all shapes, sizes, color, anything. It doesn't really matter. Just depends on you getting a sleep study. Once again, not your Apple Watch. You have to go to a doctor to get an actual sleep study. Then and only then can you be diagnosed. And once you're diagnosed, now we're talking about the treatment, okay? So everyone's seen this big, Darth Vader mask, the CPAP. Is not anything that's unusual, but this is one way to treat sleep apnea. Unfortunately, people don't want to wear it because, it's not the cutest thing in the world, but it's very effective. It does work. The second way to treat sleep apnea is wearing a mouthpiece, which I actually treat as a dentist. It goes into your mouth. It's very simple and easy to use. The third way is surgery. So there are 3 ways: the CPAP, the mouthpiece, or surgery. You can't wish your way out of it. You can't lose weight and just not have it anymore. You have to actually get treated because it will not go away. And unfortunately, untreated sleep apnea gets worse. And then once again, we're back at the heart attacks, the strokes, the diabetes.
And with these, CPAP machines, because let's be honest, no one wants to wear it. Most time patients, when they come in, they say it's just so uncomfortable for one, but also that it's not the most sexiest thing. If you're talking about someone in their 20s and 30s who has sleep apnea, they have to go on a date with someone and bring them back home to a CPAP machine. They may be hesitant to actually do that, even if they knew it could save their life. So how do you make it more of a palatable thing, for lack of a better word, for people to wear the CPAP machine? Is there something now down the pipeline that could be a little bit more user-friendly?
Well, the pipeline is here right now. There are different ways. And what I always try to impose on my doctors that are treating sleep apnea is let the patients understand there are more ways than just to wear the CPAP. Like I mentioned earlier, the mouthpiece or the custom oral appliance. We make this in our office. It's custom made just for you, and it goes in your mouth. This is it. This is the entire thing. But what it does is actually moves your jaw forward to allow more air to come in so you can breathe your own air and not have to wear the mask overnight. And there are also several surgeries out there. We try to put the surgeries out for last because it can be very invasive, but there are more than one way to do it. So I tell my patients, listen, if you cannot tolerate your CPAP, please, please, please talk to your doctor and get alternatives. And those doctors that say, no, the CPAP has to work, I challenge you, because people are not wearing these and they're on the shelf or under the bed and people are dying. So please, please, please understand, if you cannot tolerate the CPAP, please go to your doctor, find a qualified dentist, someone like me who's a diplomat, who knows what they're doing, because you can't just buy this over the counter and say it's going to work. It has to be fitted just for you. It's custom made for your mouth so that it can move properly so you can breathe.
Thank you so much, Dr. Joy Fremont. Where can people find you? If they say, hey, I don't know if my dentist, I don't know if my doctor have these mouthpiece and I want to get one specifically made for me, custom made, how can they get in touch with you in order to get one of these devices?
So I'm in Atlanta, Georgia. I'm right here by the airport, and my phone number is 404-761-1659. But if you're not in Atlanta, just go to the American Academy of Dental Sleep Medicine and look for a qualified dentist. Don't just go to someone who wants to do this. This is a medical disease that has to be treated by someone who's actually qualified. So make sure you go to the American Association of Dental Sleep Medicine, find a doctor that's nearest to you, or you can call me. I'll help you out.
You know what? Thank you again, Dr. Fremont. We will definitely have you back on the show. We need to talk about oral health and bad breath, Italy. I heard you have a character that you speak about. But
Yes.
We'll have you back on the show as soon as possible.
Thank you so much.
Up next, I'm sharing my prescription of the week. Stay with us.
They said the quiet part out loud. Black votes are a threat, so they erased them. After the Supreme Court gutted the Voting Rights Act in 2013, Republican legislatures moved fast. New voter ID laws, polling place shutdowns, purges of black voters from the rolls. Trump's Justice Department didn't stop it, they joined in. In 2018, his DOJ backed Ohio's voter purge system, a scheme that disproportionately erased black voters. Their goal, erase black votes and political power. Yeah, that happened. These are the kinds of stories that we cover every day on Roland Martin Unfiltered. Subscribe on YouTube and download the Black Star Network app. Support fact-based independent journalism that centers African Americans and the issues that matter to our community.
Your gut is running the show. We talk a lot about the brain and the heart, but there's another powerhouse in your body that doesn't get enough credit. It's your gut. It's not just where food goes, it's where so much of your health actually begins. Your gut helps control digestion, immunity, inflammation, mood, and even how your body handles stress. In fact, about 90% of your serotonin, the chemical that helps regulate happiness, is actually made in your gut. That means how you feel emotionally is deeply connected to how your gut feels physically. When your gut is out of balance, it can show up as bloating, fatigue, skin issues, brain fog, anxiety, low mood, and weakened immunity. You might think something is wrong with you, when really your body is asking for support. Stress, poor sleep, ultra-processed foods, and constant rushing all disrupt the gut. And when the gut is inflamed, the whole body feels it. Taking care of your gut doesn't have to be complicated. It can look like drinking more water, eating foods with fiber, fruits, vegetables, and beans, adding fermented foods like yogurt or kimchi, slowing down when you eat, breathing before meals. Gut health is about creating an environment where your body can thrive, because when your gut is supported, your energy improves, your mood steadies, your immune system strengthens, and your whole body works better. Wellness isn't just what you see in the mirror, it's what's happening on the inside. And your gut, well, it's the foundation. And that, my friends, is my prescription of the week. Thank you all for watching, and we will see you next week on Second Opinion.